The abdomen is, a really crowded place. You've got the liver, the stomach, all the celebrities of the digestive system.
Right, the big names.
But then you have the small intestine. It's just, what, 6 meters of tubing coiled up in the middle, doing all the heavy lifting day in and day out.
It's the blue-collar worker of the abdomen, for sure. It doesn't get the glory, but if it stops working, the whole factory just shuts down.
Exactly. And most of us, we really don't think about it until something goes wrong. But we're looking at a stack of research here today that suggests we are seriously underestimating this organ.
We are. We're diving into the Sabiston Textbook of Surgery, the 21st edition.
And this isn't just about digestion. We're talking about radioactive search and destroy missions for tumors, anatomical oddities that act like secret stomachs, and even a major rehabilitation of the appendix's reputation.
It is an incredibly dense section of the textbook. Sabiston is the gold standard for surgical knowledge. It's the Bible. And what really stands out is just the sheer variety of what can go wrong.
So the mission for this deep dive is to sort of decode how surgery in this area has evolved. It feels like a collision between high-tech molecular medicine and old-school anatomy.
That's a perfect way to put it. The small bowel was historically, the dark continent of the abdomen. It's hard to scope, it's hard to image, but that is changing fast.
Okay, so let's start with what I found to be the most futuristic concept in the text. The smart tumors.
Ah, right. Neuroendocrine tumors, or NETs.
NETs.
Yeah, these are fascinating. They arise from neuroendocrine cells, which are scattered all through the gut. So they're hybrids, part nerve cell, part hormone factory. They don't just grow, they communicate.
And because of that unique biology, the text introduces this concept of theranostics. I had to read this section twice.
It sounds like science fiction, doesn't it?
It really does.
It's a combination of therapeutics and diagnostics. And it's one of the most elegant ideas in modern oncology because you use the tumor's own biology to kill it.
Okay, so break that down for us. How does the same tool do both the finding and the killing?
It all comes down to the cell surface. These NETs almost always have a specific lock on their surface called a somatostatin receptor.
A lock.
A very distinct lock that you don't find in high density on normal cells. So scientists developed a key, a molecule that binds perfectly to that receptor.
I'm with you so far.
Now here's the theranostics part. You can attach a payload to that key. First, you attach a diagnostic isotope, something like gallium-68.
And that's radioactive.
Mildly, yes.
Yes.
It emits positrons, so you inject it, the key finds the lock on the tumor, and boom, it lights up on a PET scan. You can see exactly where every tumor is.
That's the search mission.
That's the search. But once you know where they are, you switch the payload. You use the exact same key, but instead of a flashlight, you attach a warhead.
A warhead?
Usually lutetium-177. It binds to the same receptor, gets pulled into the cell, and irradiates the tumor from the inside out.
That is incredible precision. You're not just blasting the whole area.
Exactly. But, and this is where Sabiston brings us back to the surgical reality, this high-tech weapon doesn't fix the physical mess these tumors create. There's this thing called the desmoplastic reaction.
The text described this vividly. It said the mesentery, the tissue holding the bowel, gets pleated.
Think of the mesentery like a broad, flat bed sheet that spreads out the intestines. These tumors secrete things, like serotonin, that cause intense scarring. It's like taking that bed sheet and pulling a drawstring tight in the middle.
So the intestine gets kinked out.
Kinked, twisted, folded into a knot. The text calls it intestinal angina. The bowel is literally starving for blood because the vessels are being strangled.
Which explains why the surgery is so difficult. You're not just removing a lump, you're untangling a concrete knot.
It is a minefield. And to make it even higher stakes, Sabiston warns about something called carcinoid crisis.
This sounded terrifying. The idea that just the anesthesia could crash a patient's whole system.
It's a very specific risk. These tumors are hormone factories. If you stress them during surgery or even just during anesthesia, they can panic and dump all their hormones at once.
Like a serotonin bomb.
Exactly. Blood pressure bottoms out, the patient turns bright red, their airways constrict. It can be fatal right there on the table.
So what do?
You have to be prepared. The text says you must have octreotide on hand. It's a drug that basically puts a lid on the tumor. But the big takeaway from Sabiston is that despite all this, surgery is usually the right call.
Even if the cancer is spread.
Yes. That's what's so unique. For most cancers, metastatic disease means you don't operate. But with NETs, because they grow so slowly, debulking, just removing as much tumor as you can, actually extends survival and improves quality of life.
Wow, okay, so that optimism seems to just vanish when the text moves on. We go from smart tumors to what felt like the thugs of the neighborhood, adenocarcinoma and lymphoma.
Yeah, the tone of the textbook shifts noticeably there. Adenocarcinoma of the small bowel is a nasty disease. The prognosis is poor.
Why is there such a huge difference compared to the nets?
It is biologically aggressive, but the main killer is the vagueness. The small bowel is a big, stretchy tube. A tumor can grow there for a long time without causing a blockage.
So the patient just doesn't know.
They might have some vague belly pain, maybe lose a little weight, things you just dismiss. By the time it causes real symptoms, it's often too late.
Sabiston did mention an exception, though, about location. Duodenal tumors are found earlier.
Right. It's all about real estate. The duodenum is the first part of the small intestine, and it's where the bile duct empties into the gut.
Ah.
So if a tumor grows there, it blocks the bile duct almost immediately.
And blocked bile means jaundice. You turn yellow.
And people don't ignore turning yellow, they go to the ER.
Yeah.
But if that same tumor is 10 feet further down, it can hide for years.
That's terrifying. Now, for lymphoma, the text pinpointed the ileum as the hotspot.
It did, and there's an anatomical reason for that, too. Lymphoma is a cancer of the immune system. The ileum, the final section of the small bowel, is absolutely packed with lymphoid tissue called Peyer's patches.
So the cancer goes where the immune cells live.
Precisely. But the really scary part about small bowel lymphoma, and the text flags this as a huge risk, is perforation.
A hole in the gut.
Yes. Sometimes the tumor grows so fast it outstrips its own blood supply and just crumbles. Or, ironically, the chemotherapy works so hot that it melts the tumor away, leaving a hole where it used to be.
Wait, so the treatment can actually cause the emergency?
It can, which is why you have to know the specific cell type. B-cell lymphomas respond great to chemo, but T-cell lymphomas, they are stubborn, resistant, and have a high risk of perforation. So for T-cell, you often have to cut it out first.
It really feels like pathology drives the entire strategy here.
Absolutely. You can't just treat a mass anymore.
Well, speaking of that, we have to talk about GSTs, gastrointestinal stromal tumors. The text calls the treatment a paradigm shift.
GISTs are one of the greatest success stories in modern medicine. 20 years ago, they were a death sentence. Now, they're the poster child for targeted therapy.
But before the drugs, there was a surgical rule that was practically in bold print. It said, do not rupture the capsule.
That is rule number 1. GISTs are soft, fragile tumors. If a surgeon is rough and pops that capsule, it spills tumor cells everywhere in the abdomen.
And the consequence is bad.
It's catastrophic. The text cites a stat, nearly 100% relapse if rupture occurs. You turn a curable cancer into a recurring nightmare.
So you handle it with extreme care. But let's say you get it out. This is where the magic bullet comes in. Imatinib or Gleevec.
This drug changed everything. Scientists found that GISTs are driven by a specific genetic mutation, usually in a gene called KIT.
And what does that mutation do?
So imagine a light switch inside the cell that controls growth. In a GIST, the mutation jams that switch in the on position. The cell just keeps dividing nonstop.
And imatinib.
Imatinib is a molecule designed to fit perfectly into that switch and physically force it, off.
It cuts the power.
It cuts the power. It stops the signal. We went from having no good drugs for these tumors to a pill that can melt them away.
Though the text does mention that. Biology is clever. Resistance happens.
It can. The tumor can mutate again so the drug doesn't fit anymore. Sabiston specifically mentions the D842V mutation.
Alphep soup, but it matters.
It matters immensely because imatinib won't work on that one. You need a different drug. It just reinforces that theme. You have to know the specific molecular machinery of the cancer.
So we've covered tumors, but sometimes the small intestine causes trouble without a single cancer cell. Let's talk about the anatomical oddities.
The congenital defects. Things you're born with that might not show up until you're 40.
You mentioned the windsock deformity. I am having a hard time visualizing this inside a person.
It's a type of duodenal diverticulum. So imagine a windsock at an airport. Now picture a membrane like that inside the duodenum. As food moves down, the windsock fills up and balloons out.
And that creates a blockage.
It can, but because of where it sits, right near that bile duct again, it can also press on the opening of the pancreas or liver and cause pancreatitis or jaundice, a mechanical problem causing a chemical crisis.
But the king of all these anomalies has to be Meckel's diverticulum.
Every med student memorizes the rule of twos for Meckel's. 2% of the population, 2 feet from the end of the small bowel, 2 inches long.
It's a leftover piece of the umbilical cord, right?
Exactly. A remnant of the vitelline duct. It should disappear, but sometimes it stays as a little pouch.
But the part that blew my mind is what can be inside that pouch, the second stomach.
This is the crazy part. About half of them contain ectopic tissue. Most commonly, it's gastric mucosa,
Stomach lining.
actual acid-secreting stomach cells, just sitting way down in the ileum.
And the ileum is not built to handle acid.
Not at all. The stomach has a thick mucus layer to protect itself. The ileum doesn't, so this little patch of tissue starts pumping out acid and burns an ulcer in the healthy bowel right next to it.
Which is why the main symptom is bleeding.
Painless bleeding, exactly. And this leads to a really cool diagnostic trick. You order a technetium 99-meter scan. The tracer they use loves gastric mucosa.
So it goes to the stomach.
It goes to the stomach, so the stomach lights up. But if there's a Meckel's, you see a second little glowing hot spot down in the lower right abdomen. It finds the second stomach.
That is brilliant. But there's a debate, right? If you find one by accident during another surgery, do you take it out?
The incidental Meckel's debate. It's a classic surgical argument. For years, the thinking was, if it ain't broke, don't fix it.
But Sabiston suggests the pendulum is swinging back.
It is. Newer data suggests that Meckel's might be a hotspot for developing cancer later in life. So now, the text suggests that if you're already there and the patient is, say, male or under 50, you should probably just take it out.
Okay, speaking of taking things out,
Yeah.
let's talk about the appendix.
The poor appendix.
For as long as I can remember, I've been told it's a useless evolutionary mistake. But this text suggests it actually has a day job.
A very important one.
Yeah.
The safe house theory.
A safe house for what?
For your good gut bacteria, your microbiome. The theory is that the appendix is a reservoir. Think about what happened to our ancestors when they got, say, cholera.
It flushes the entire system out.
Wipes the slate clean, you lose all your good bacteria, but the appendix is this little blind alley that doesn't get flushed out as easily. So once the infection passes, the good bacteria emerge from the appendix like an army coming out of a bunker to recolonize the gut.
That makes so much sense. Is there actual data for this?
There is. The text notes that patients who've had their appendix removed have a harder time recovering from C. difficile infections, which is a bug that takes over when your good bacteria are gone.
So we shouldn't be so quick to dismiss it. But obviously when it gets inflamed appendicitis, it still has to go.
Oh, absolutely. A perforated appendix is life-threatening. You don't mess with that.
I found the section on diagnosis interesting, how it describes the pain moving.
The migration of pain, it's
Great.
the classic tell. It starts as a vague, dull pain around the belly button. That's visceral pain.
But then it shifts.
Right. As the appendix gets more inflamed, it touches the lining of the abdominal wall. That tissue has very precise nerves, so the pain suddenly becomes sharp and moves specifically to the right lower quadrant.
And doctors actually score this.
The Alvarado score, yeah. You get points for migration of pain, loss of appetite, rebound tenderness. It helps decide who needs a CT scan.
Which is still the gold standard.
In adults, yes,
Yeah.
you look for that target sign. But Sabiston is careful to note, in pregnant women or kids, you avoid the radiation and use an MRI or ultrasound.
So we've talked about removing all these different parts. What happens when you remove too much? The text discusses short bowel syndrome.
This is one of the toughest complications in GI surgery. If a patient has less than 200 centimeters of small bowel left, they just can't absorb enough nutrients or fluids.
They become dependent on IV nutrition.
TPN, or total parenteral nutrition. It keeps them alive, but it's a hard life. It's tough on the liver, and the lines can get infected.
But the bowel is resilient. The text talks about adaptive hyperplasia.
The gut tries to hulk out.
Hulk out.
In a way. The remaining bowel literally grows. It gets thicker. The little fingers that absorb food get longer. It tries to increase its surface area to compensate.
And we can help it do that now. I saw a drug mentioned, teduglutide.
This is another big molecular win. Teduglutide is a GLP-2 analog.
GLP-2. Everyone is talking about GLP-1s right now, like Ozempic. Are they related?
They're cousins.
Hmm.
Both are hormones from the gut. But while GLP-1 slows things down and makes you feel full, GLP-2 is a growth factor. It tells the intestinal lining to grow and absorb more.
So it boosts that natural adaptation process.
Exactly. For some patients, this drug has meant they can get off IV nutrition entirely. It gives them their life back.
That really ties everything together, doesn't it?
Yeah.
We started with radioactive keys for tumors, and now we're talking about growth hormones for the gut itself.
It's the theme of this whole deep dive. Surgery isn't just anatomy anymore, it's biology. The small bowel is an endocrine organ, an immune organ, and a digestive organ. You have to respect all those layers.
And maybe respect our appendix a little more, too.
Definitely. I think it's earned its keep.
We've covered so much ground today. from the theranostic future of cancer care to the second stomach hiding in a Meckel's. It really changes how you see that winding tube in your abdomen.
It's certainly more than just a sausage casing.
Before we wrap up, I want to leave you with one final thought based on that safe house theory.
Okay.
We've been doing appendectomies for over a century. It's one of the most common surgeries in the world. So there are millions, maybe billions of people walking around without their bacterial safe house.
That is a massive variable in the human experiment.
So if the appendix really is our microbiome's backup generator, how might those millions of surgeries be subtly reshaping our collective health? Are we as a species becoming more vulnerable because we've been systematically removing our safety net?
That is a profound question, and we might not know the answer for another 100 years.
That's something to chew on. Thanks for joining us on this deep dive into the small bowel. We'll see you next time.